Welcome to the second section of your course, where we dive deeply into airway management, respiration, and ventilation. In this critical lesson, you will learn the anatomy of the respiratory system, how to recognize signs of breathing distress, and how to effectively use various oxygen delivery and ventilation devices. This topic is incredibly important, because securing a patient airway and ensuring they are breathing adequately is the most vital, life-saving intervention you can perform as an emergency medical technician. You should feel excited to learn these concepts, because mastering these skills means you will literally have the power to breathe for someone who cannot breathe for themselves. Prepare yourself for an engaging lesson, as we explore the ultimate foundation of pre-hospital emergency care. And to truly master these foundational concepts as we begin, I highly recommend obtaining our practice tests or downloading the offline app, which are excellent educational tools to help gauge your readiness. To understand airway management, we must first look at the anatomy of the upper airway, which includes the nose, mouth, pharynx, and larynx. The primary function of the upper airway is to warm, filter, and humidify the air as it enters the body, preparing it for the delicate structures lower in the chest. A common exam tip is to remember that the larynx, also known as the voice box, serves as the dividing line between the upper and lower airway. Any swelling or blockage above this line, such as a severe allergic reaction or a piece of choking food, will immediately threaten the ability of your patient to breathe. Below the larynx lies the lower airway, consisting of the trachea, the bronchi, the smaller bronchioles, and finally the alveoli. The alveoli are tiny, balloon-like air sacs at the very end of the airway where the actual magic of gas exchange happens. When a patient inhales, oxygen travels down into these tiny sacs and passes into the bloodstream, while carbon dioxide moves from the blood into the sacs to be exhaled. Understanding this microscopic exchange is vital, because any fluid or damage inside the alveoli will stop oxygen from reaching the brain, leading to rapid deterioration. A common trap on the certification exam is confusing the terms ventilation and respiration, but they have two very distinct meanings in the medical world. Ventilation is simply the mechanical process of moving air in and out of the lungs, much like a bellows pumping air into a fire. Respiration, however, refers to the actual exchange of gases, either in the lungs or down at the cellular level throughout the body. You can mechanically ventilate a patient perfectly, but if they have a condition like carbon monoxide poisoning that blocks cellular respiration, they will still suffer from a lack of oxygen. Before you can treat a respiratory emergency, you must be able to recognize what normal, adequate breathing looks like during your patient assessment. A healthy adult will breathe at a rate of 12 to 20 breaths per minute, with a regular rhythm and a normal, effortless depth. When you listen with your stethoscope, the breath sounds should be clear and equal on both sides of the chest. If your patient meets all these criteria, their breathing is adequate, and they likely do not need aggressive airway interventions, though they may still benefit from supplemental oxygen. When a patient struggles to breathe, they enter a state called respiratory distress, which you must catch early before they become completely exhausted. Signs of respiratory distress include breathing faster or slower than normal, using accessory muscles in the neck and chest to pull in air, and flaring of the nostrils. You might also find the patient sitting forward in a tripod position, hands resting on their knees, trying desperately to expand their chest. The exam will expect you to recognize these early warning signs and immediately apply supplemental oxygen to help ease their workload. To see how these clinical scenarios translate into actual exam questions, utilizing our practice tests or working through the offline app can provide an incredibly realistic study experience. If respiratory distress is left untreated, or if the patient becomes too tired to keep breathing hard, they will slip into respiratory failure. Respiratory failure is a life-threatening emergency characterized by an altered mental status, extremely shallow breathing, and a dangerous drop in their breathing rate. You might also notice their skin turning a bluish color, known as cyanosis, which is a late sign of oxygen starvation in the tissues. When an exam scenario describes a patient who is breathing only 6 times a minute and is suddenly difficult to wake up, you must recognize this as respiratory failure and begin artificial ventilation immediately. The very first step in treating any unconscious patient is to manually open their airway, lifting the heavy tongue away from the back of the throat. If the patient has a medical complaint with no suspected trauma, you will use the head tilt chin lift maneuver to tilt the head back and open the airway. However, if there is any suspicion of a neck or spinal injury, such as from a car crash or a fall, you must use the jaw thrust maneuver instead. Exam questions constantly test this rule, so always remember to protect the cervical spine by using the jaw thrust on trauma patients. Once the airway is manually opened, you will often insert an airway adjunct to help keep the tongue out of the way, starting with the oropharyngeal airway, or OPA. The OPA is a curved piece of plastic inserted into the mouth, but it can only be used on completely unconscious patients who do not have a gag reflex. To measure it correctly, you place it against the patient's cheek, measuring from the corner of the mouth to the earlobe. If you insert an OPA and the patient gags, you must remove it immediately, as it can cause them to vomit and choke. If your patient has an intact gag reflex or is only semi-conscious, you will use a nasopharyngeal airway, commonly called an NPA. The NPA is a soft rubber tube inserted through the nose, and it is measured from the tip of the nose to the patient's earlobe. You must lubricate this tube well before gently sliding it into the right nostril, with the bevel facing the septum. A major exam tip is to avoid using an NPA if you suspect severe head trauma, particularly a basilar skull fracture, because the tube could accidentally be pushed upward into the brain cavity. Sometimes the airway is blocked by vomit, blood, or thick secretions, which means you must use a suction unit to clear the path. You will typically use a rigid plastic tip, known as a Yankauer catheter, to suction out the mouth and back of the throat. The golden rule of suctioning, which is highly tested, is to apply suction only while withdrawing the catheter, sweeping from side to side. Furthermore, you must never suction an adult for more than 15 seconds at a time, because the machine removes vital oxygen along with the fluids. when it comes to providing supplemental oxygen. You will carry high-pressure oxygen cylinders that must be handled with great care and respect. These tanks use a specialized regulator to drop the intense pressure down to a safe, usable level before the oxygen reaches the patient. You must change the oxygen tank when the pressure drops to 200 pounds per square inch, which is considered the safe residual pressure. Always keep your tanks secured and lying flat when not in use, because a damaged valve can turn a heavy cylinder into a dangerous high-speed missile for patients in mild respiratory distress, or those who simply need a little extra oxygen. The nasal cannula is the best delivery device. It features two small prongs that rest in the nostrils, delivering a low flow of oxygen between 1 and 6 liters per minute. This flow rate provides an oxygen concentration of roughly 24 to 44%, which is often enough for a stable medical patient. The nasal cannula is also the perfect alternative for patients who feel claustrophobic or refuse to wear a tight-fitting mask over their face. When a patient is in severe respiratory distress, shock, or trauma, you need to deliver a high concentration of oxygen using a non-rebreather mask. This mask covers the nose and mouth and features an attached reservoir bag, delivering up to 90% oxygen when hooked up to a high flow rate. You must set your oxygen regulator between 10 and 15 liters per minute, ensuring the reservoir bag is completely inflated before you place the mask on the patient. The exam will frequently point you toward the non-rebreather mask for any unstable, critically injured, or severely short of breath patient. If a patient is in respiratory failure or completely stops breathing, which is called apnea, oxygen masks will no longer work, and you must step in to breathe for them. This is called artificial ventilation, and the most common device used by emergency medical technicians is the bag valve mask, or BVM. For an adult patient, you must squeeze the bag once every 5 to 6 seconds, delivering just enough air to make the chest rise visibly. A classic exam question will ask how you know your ventilations are effective, and the answer is always looking for adequate and equal chest rise. Using a bag valve mask alone can be extremely challenging, because maintaining a perfect, airtight seal on the face while squeezing the bag with your other hand is difficult. Therefore, two-person bag valve mask ventilation is always preferred and strongly recommended by national guidelines. One rescuer uses both hands to hold the mask tightly against the face using the EC clamp technique, while the second rescuer uses two hands to squeeze the bag smoothly. The EC clamp technique involves using your thumb and index finger to form a C shape around the mask, while your remaining 3 fingers form an E shape to lift the jaw upward. A very common and dangerous complication of using a bag valve mask is causing gastric distension, which happens when you force air into the stomach instead of the lungs. This occurs when you squeeze the bag too fast, too hard, or when the patient's airway is not positioned correctly. As the stomach fills with air, it puts pressure on the diaphragm, making it harder to breathe, and greatly increases the risk of the patient vomiting. To prevent gastric distension, ensure the head is tilted back properly, and squeeze the bag gently, stopping the moment you see the chest begin to rise. Another advanced tool in your airway kit is continuous positive airway pressure. commonly known as CPAP, which is used for severe distress in conditions like asthma, pulmonary edema, or chronic obstructive pulmonary disease. CPAP uses a tight-fitting mask to blow a continuous stream of pressurized air into the airway, keeping the tiny alveoli open and pushing fluid out of the lungs. However, a major rule for the exam is that a patient must be fully conscious, alert, and capable of breathing on their own to use CPAP. If a patient becomes exhausted or their mental status drops, you must remove the CPAP mask and immediately switch to a bag valve mask. As you prepare for the exam, you must remember that pediatric airways are not just small adult airways. They have unique anatomical differences that change how you manage them. Children have proportionately larger tongues that easily block the airway. Their tracheas are softer and can collapse if you tilt the head back too far. And they rely heavily on their diaphragm to breathe. When opening the airway of an infant, you must place a small towel pad beneath their shoulders to keep their large head perfectly neutral, preventing the soft airway from kinking. Exam scenarios will frequently test your ability to adapt adult airway techniques safely for these smaller, more fragile patients. I want to congratulate you for completing this critical section on airway management, respiration, and ventilation. I strongly encourage you to complete the attached practice tests for this specific lesson right now, or log into the offline app to continue testing yourself on the go, as answering these targeted questions is the best way to improve your knowledge retention and overall exam readiness. You will find that the practice tests and offline app are included with this course to help you solidify these crucial airway concepts through active learning. Please continue this process, as it truly makes a huge difference in your final exam scores. I naturally look forward to seeing you in the next section, where we will explore the exciting and fast-paced world of cardiology and resuscitation. So keep up the fantastic work and stay focused on your success.